Hi, it's Tom here from Running Physio, and in today's video I want to talk to you a little bit about differential diagnosis for anterior knee pain. Now this is very much an umbrella term, but I think it's not really that helpful. It's pretty much just saying to someone you've got a bit of a hurty knee. So in this video we want to explore some of the potential causes for anterior knee pain. Now this is a complex topic. You could talk for 2 or 3 hours on this and delve into all the tests and things. We're not going to do that. We're going to just have a look at a quick overview of some of the differential diagnoses that we should consider. Also, I want to start by thinking, does the diagnosis actually change management? Now that's one of the things when we put a diagnostic label on it, sometimes it can have negative consequences. Patients go off and Google it, don't they? And they often find the worst case scenario, and that increases their fear and worry. Sometimes that diagnostic label can lead to tunnel vision with us because we start to see a diagnosis rather than a person, and we slip into the familiar patterns of treating that diagnosis. So we need to be aware from the start there can be some negatives to being very diagnosis focused. But we can also see that sometimes it really does change management. And an example here in anterior knee pain, if you have someone where you think that they have some patellar tendinopathy, and you send them off, load them up with lots of heavy resisted open kinetic chain knee extensions on a knee extension machine, and it turns out it was patellofemoral pain, that might well really stir it up, because that type of exercise can be really challenging for someone with patellofemoral pain. So it can influence things, particularly around exercise selection and management. There's going to be a lot of overlap still though. We still want to talk about load management, education, etc., but it can make a difference to some aspects of care. So let's talk about probably the most common cause of anterior knee pain, certainly that I see in runners, which is patellofemoral pain. Now, typically we're going to have pain around the patellofemoral joint. It's going to be aggravated by positions that load that joint. So often we'll see pain with running, but also deeper squatting, going up and down stairs potentially, and heavy resisted open kinetic chain work. When you examine it, you'll often find there is some tenderness around the joint on palpation, particularly sometimes around the lateral patellar facet. So those would be the typical symptoms. Very common in female runners, more common in female runners than it is in men. And we do see it also being quite prevalent in adolescent populations as well. So we want to think when we're making these working diagnoses, how does it fit with the population we're seeing here, with their presentation, with their pain? We've also got to be a bit careful that we're not blaming a structure for symptoms. And with patellofemoral pain, there is evidence of central sensitization, of hypersensitivity in the tissues around the knee, which seems to be increased when runners increase their training. So be careful we don't just blame a structure. There's a lot more that's going to influence pain. So first up, we have our patellofemoral pain syndrome, and I think many of us are fairly comfortable with the classic signs and symptoms of that. Next up on the list, we have bursitis. Now actually there are 4 different bursa around the knee, but the most commonly involved one is the pre-patellar bursa. And classically what you might expect to see is a swollen tender pre-patellar bursa, and often it's going to be aggravated by things like kneeling on that area. Now, there can be a number of different causes for bursitis. The most common cause is repeated microtrauma. So that might come from repeated actions, perhaps an elite cyclist doing the same movement over and over again, or repeated microtrauma from kneeling, which eventually irritates the bursa and causes it to swell. Also important to recognize in bursitis is it can be caused by infection. And there's some evidence to suggest that if that bursa feels warm, noticeably warm to the touch, that can indicate there could be an infection driving that bursitis. And if you suspect infection, it does need to be checked out. You want to get blood work done. You may choose to aspirate it or arrange someone to aspirate it to find out a bit more about what's going on. Bursitis can also be associated with inflammatory arthropathies, so that's something to consider as well. Now, in terms of managing these bursitis, often it's going to be important to try and reduce the source of this microtrauma if that's causing it. So we see it sometimes in people that tradesmen and women who are laying carpet, they're kneeling down all day as part of their job perhaps. We need to try and make sure they've got appropriate padding for their knees. We try and break up that kneeling as much as possible. You might look at things like anti-inflammatory treatments and things as well to try and calm it down. So that's bursitis in a nutshell, and just be aware of infection as a potential cause. Next up, we have tendinopathy. Now, the most common form of tendinopathy we'll see presenting with anterior knee pain is patellar tendinopathy. Now, the pain location tends to be a little bit different from patellofemoral pain. So it's often the inferior patellar pole where you'll get symptoms, a little bit less likely than surrounding that patellofemoral joint. And you'll often be able to recreate those symptoms on palpation, although that's not always the case. It does seem to depend on how irritable they are. And with tendinopathy, we're more likely to see things like early morning stiffness, particularly if it's quite irritable, and the warm-up effect we get with tendon pain. So by that, what I mean is they might be sore at the start of an activity, but as they keep going, it warms up and it feels better. That's a classic tendon behavior. You also see a latent pain response in tendinopathy, so the pain may not kick in until a day or two after a provocative activity. So if you're seeing these things, early morning stiffness, the warm-up response, maybe a latent response to pain, and the pain's more located around that inferior patellar pole, that's going to lean me a little bit more towards patellar tendinopathy as a potential cause. The aggravating factors do overlap with patellofemoral pain syndrome. So, for example, single leg squats and single leg decline squats will be painful, but that's often the case with an irritable patellofemoral joint as well. So we have to look at that pain location, that pain behavior, and again look at the population. Patellar tendinopathy is really common in jumping athletes. So if you're working with someone who is playing basketball or volleyball or a competitive sport with lots of jumping in it, that might lead me a little bit more towards suspecting patellar tendinopathy as a cause. Now, less common and often forgotten is quadriceps tendinopathy. Now, with this, we tend to see pain where the quads attach around the kind of top of the patella itself, and it's often aggravated more in deep knee flexion positions. So when you're rehabbing it, you often want to work outside of those deep knee flexion ranges, at least initially, until symptoms settle. It does actually respond quite well to a similar approach to patellar tendinopathy in terms of load management, education, and progressive strength work, but it may well be that range of movement that you're going to change, so you're not loading into so much flexion. As ever, though, of course, we're going to be guided by the patient and their symptoms and their response to the exercises that we're doing. So we talked a bit about patellofemoral pain, bursitis, and tendinopathy. Next up on our list is the fat pad. Now, there are actually 3 different fat pads in the knee, but the most commonly injured is the infrapatellar fat pad, or Hoffer's fat pad. Now, this can cause like a burning, aching sensation around that fat pad, which is often kind of just deep to the patellar tendon or surrounding that patellar tendon region. And it can coexist with patellar tendinopathy or patellofemoral pain syndrome. So there can be a bit of an overlap here. And that's another point, really. It's quite possible people will have perhaps 2 or 3 areas that may be related to their pain. Now, typically we see this as being aggravated in knee extension and knee hyperextension potentially. And that's where you might choose to do your Hoffer's fat pad test, where you're palpating that fat pad and moving into extension to see if it brings on their symptoms. And this again is a little bit different, slightly different presentation to patellofemoral pain and patellar tendinopathy, where they're often in pain when they're loading into some flexion as they're starting to go down the stairs or into a squat. This is more typically irritated in those extended positions. And it might be related to postures. So sometimes you see with patients that they're a bit hypermobile and they like to rest in knee hyperextension. So if they're telling you they get pain with prolonged standing, and you look at their standing posture and they tend to like to sit in that hyperextended position, it can sometimes help by trying to get them to soften their knees and stand in a little bit of knee flexion. In terms of demographics, it's thought to be a little bit more common in the middle age groups. So again, that might help you to differentiate in terms of the populations that you're seeing. Next up, sort of finally really on our list, is Pliker. Now, Pliker can be a little bit controversial, and again, there's several different Plikers. There's actually 4 around the knee, but it's the medial Pliker which is the most commonly symptomatic. Now, this patients will often describe some medial pain that is associated with a click, a grind, a pop, or a crunch when they move, particularly if they're moving from flexion into extension. And you might be able to see that in clinic. You might actually have what's called a positive stutter test, whereas if you feel the patella as someone moves from knee flexion to extension in sitting, you might actually feel that stutter of the patella that's associated with the Pliker. Now, there's thought to be an inflammatory component to this, so sometimes you can have some signs like that, like night pain. You might see evidence of swelling and things as well. So if you're getting that clicking, popping sensation with movement, if the symptoms are a bit more medial, maybe if there are night symptoms with it as well, that should lead us into suspecting that possibly there might be some Pliker involvement. And again, the management here might be slightly different. So there are, for example, steroid injections that are considered sometimes to be an option, even surgical options as well. Again, for most of these, load management, progressive strength and conditioning education is going to be helpful, but for each there might be just a slightly different approach in things like exercise selection and management, which will influence what you do. Now, finally, one that probably doesn't really come under the anterior knee pain banner, but sometimes gets thrown in there, would be iliotibial band syndrome. Now, this is more classically lateral symptoms around the ITB. It often is a really sharp sensation, and runners will often say it comes on quite quickly and it feels like very sharp, tight pain around the lateral knee that stops them running. It's often painful when the knee's loaded in about 30 degrees of knee flexion, and you might have a positive Noble's test, which is where you palpate the ITB when someone is moving into about that 30 degrees of knee flexion. Now, this then again will need to be treated. There's going to be load management and education and things involved, but we think that gluteal weakness may be a significant piece of the puzzle here. And of course, there's overlap there with patellofemoral pain syndrome as well. So there's a bit of a whistle-stop tour of some of the potential causes of anterior knee pain. There are others. I'd like to hear what you think. Are there any particular tests you find useful? Any differential diagnoses I've missed off the list here? Let us know in the comments and replies. And if you'd like to find out lots more about running injury assessment and treatment, do check out our free webinars. I've included a link there for you on those. We've got a great collection of several different free webinars that you can access directly on that page, and I think they'll be really helpful for you and help you treat your runners that you see in clinic. Okay, if you've enjoyed the video, do feel free to like and to share. These videos are for you. We want to get them out there and really see if we can help people. And if there's something you'd like us to cover, just let me know. Put a comment in the replies. We'll try to do these each week, roughly around lunchtime on a Friday. So if there's a topic you'd like me to cover, if you've got questions about a particular runner pathology you don't feel comfortable with, maybe something around gait analysis you're not sure about, let us know, because then I can put together a video to help you. Okay, thanks again for listening. Bye for now.